antioxidant vitamins like vitamin C could potentially protect against bronchopulmonary dysplasia. However, parenteral multivitamin preparations given without light protection, and by light protection I mean, I don't know what your units are like, but when you give TPN, you have the bag of TPN, and in our units we covered that bag of TPN with a brown plastic bag so that you can actually look through and see what fluid is in there, but it's dark enough that it prevents light from getting through. So that's photoprotection, and we also use it not only in the TPN bags, but we use for intravenous lines that go in. We will, with lipid administration, we will cover that with the dark colored brown tubing also to protect, photoprotect the lipid as it's running through into the baby. So going back to this, however, parenteral multivitamin preparations given without light protection are a major source of peroxides, which have been demonstrated to worsen lung disease. Exposure of parenteral multivitamin preparations to light generates peroxides, which in animal models at least induce oxidant stress in the lung. So the fact that vitamin E didn't work very well in previous studies may be because people weren't covering their TPN bags which had vitamin E in it. There was breakdown of the vitamin E by photodegradation, and this may explain the demonstrated absence of vitamin E supplementation on benefiting chronic lung disease. Now, much of this work is done by Philippe Chassé and colleagues in Canada, and they did a single study that demonstrated that photoprotection of TPN increases advancement of minimal enteral nutrition in preterm infants. And they did a study where they divided babies into infants who had photoprotection and non-photoprotection, and they saw significant ability to advance trophic feeds more quickly in those babies who had photoprotection of their TPN. So Chassé is continuing to do a lot of work in this area, and I think he's got some very interesting findings. There's an article that came out in Journal of Pediatrics this past year, and the question they asked is the risk of developing BPD influenced by failure to protect TPN from ambient light exposure. And they've done a number of animal and human studies, and in their laboratory studies they've shown that the oxidant load associated with TPN causes adverse effects on biochemical and histologic variables in the lungs. So just this oxidation actually decreases lung function and structure. Shielding TPN from light protects the lung against remodeling, which is a hallmark of BPD. So they went back and looked at all the infants they had photoprotected or not photoprotected over the years, and of a post hoc analysis, so this is a study, an analysis after the study was done, of infants from a prior study on TPN, they felt that shielding TPN showed protecting TPN from light is associated with a 30% reduction in BPD. So they hypothesized that if you could cover all of your TPN bags and your lines of lipid running into a baby, you could, by that strategy alone, decrease BPD by 30%. And that's a staggering estimation. When we look at how severe bronchopulmonary dysplasia is, the financial costs, etc., something as simple as covering the TPN bags could reduce the incidence of that disease significantly. So now Chassé and colleagues are proposing a large, multi-center, randomized controlled trial of 1,000 infants to determine an optimal modality of TPN preparation for preterm infants that will improve respiratory and developmental outcomes. We were invited to participate in that study, but our nursery nurses refused to participate because they so strongly believed in photoprotection that they didn't want to be in the control group that didn't have photoprotection. So we're not part of that study, but it'll be interesting to see what the final results are. Next slide. Briefly, This is familiar to all of you. Causes of poor growth and bronchopulmonary dysplasia. They often required fluid restriction, diuretics, long-term parenteral nutrition, enteral feeding intolerance, gastroesophageal reflux. Some of them are still on steroids, which can affect their growth. They clearly have increased energy expenditure in most cases. They fatigue easily, and they often are taking a variety of other medications that could influence their growth. So what should be the nutrition for infants with bronchopulmonary dysplasia? A recent systematic review of studies assessing the adverse effects, growth, and developmental outcomes in infants with BPD getting standard, just routine increased energy intake was unable to find any eligible trials for evaluation. So I mentioned that earlier. Even though we're used to giving a lot of carbohydrates, it has not been used in other types of energy to preterm infants. It's not really been targeted for a nutritional strategy in infants with BPD. Excellent. In terms of protein, fairly recently, Richard Cook and his colleagues have shown, they did a study that showed a higher enteral protein intake, greater than 3 grams per kilo per day, but less than 4, versus lower enteral protein intake, less than 3 grams per kilo per day, improved weight gain and protein accretion without adverse effects. So even though this study was a post-discharge study that was not done in infants with chronic lung disease, these outcomes from this study would suggest they might be beneficial in infants with bronchopulmonary dysplasia, again suggesting a beneficial role of increased protein. In terms, as I mentioned, in terms of nutritional management in BPD, there have been very few studies in the post-steroid era. So I'm going to talk just briefly, finish my talk briefly, talking about a study by Stephanie Atkinson and her colleagues Saigal and Brunton. And they did the first study showing that the ability to attain catch-up growth could occur in patients with BPD. They did a blind trial of 60 preterm infants with BPD, and they randomized them to the isocaloric, so they had the same number of calories in the two formulas, from 37 weeks to 3 months corrected age. There's a standard formula and an enriched formula. Again, the same calories, but enriched with protein and minerals. And they did follow-up at 1 month and 3 months corrected age. And this is their randomized trial of high energy versus low energy versus high energy nutrient-enriched formula post-discharge. And this, again, this where the energy intakes the same amount of energy in the standard formula versus the enriched. But with the other nutrients, they increased their content significantly. So for example, protein in these infants was increased, and this is a percent increase, by over 50% in their enriched formula. The calcium was increased by over 250%, phosphorus by 220%, sodium significantly increased, iron increased, potassium, and osmolality was increased slightly. So all of these nutrients were increased in this study. Excellent. And these were the outcomes. And the star represents a significant difference. So in the enriched formula compared to standard, actually the weight wasn't much different, which you might expect because they got the same caloric intake. However, protein accretion was significantly greater, calcium balance was greater, as was zinc balance, phosphorus balance, and overall nitrogen balance. And when they followed up these infants at 3 months corrected age, the enriched formula group had significantly greater growth and length, lean mass, radial bone mineral content. Male infants had greater whole body mineral content, more than females. There was faster catch-up growth with the enriched formula. Of interest, though, and this was unanticipated, that in the infant standard formula, 6 out of the 13 infants had negative zinc balance, suggesting a possible zinc deficiency contributing to the lower lean mass accretion in the standard formula group. And again, I think in the last few days, if we've talked about nutrients, we haven't discussed the role of zinc to a great detail, and that may be something to consider in our new formulations, especially for post-discharge infants. And this is my last slide. And Stephanie was kind enough to give me the guidelines that she used. And again, these are the only guidelines I was able to find for nutritional management of infants with bronchopulmonary dysplasia. And she divides her guidelines into two parts. Early life, neonatal life, well, they're still in the hospital. And then she's got different recommendations for babies who are stable in a growing period around the time of hospital discharge or for several months after. So in the early period, she recommends vitamin A, and they do use vitamin A in their urine, and they give it intramuscularly 3 times a week for 4 weeks. They've also given it orally at times once enteral feedings are established. So this may be a good alternative to the vitamin A dilemma, giving enteral feedings. They give vitamin E up to 4 to 5 milligrams per day, and that is pretty much enough to maintain normal vitamin E levels. And fluid restriction. And if the fluid intake is restricted to less than 150 mLs per kilo per day, which it commonly is in infants who have chronic lung disease, they then provide high nutrient density feedings as tolerated. Once babies get on to be older, at least 3 months corrected age, they're stable, they're growing, these are their target intakes, at least 3 grams per kilo per day of protein, and based on Rich or Cook's data, you may want to go as high as 4 grams. They supplement with phosphorus, zinc, vitamin D, and relatively high amounts of vitamin D. They provide energy at approximately 120 kcals per kilo per day and calcium supplementation. And if fluid restriction is required, they then add modular nutrient supplements like independent lipid, carbohydrate, and protein to breast milk or to preterm formula to try and enhance growth. Next slide. So in conclusion, there's still much to be learned about nutritional strategies in chronic lung disease, both to optimize short and long-term growth, lung repair in these infants with chronic lung disease. Thank you.